Alma said, I'm Anna. I am a medical student from Brazil, but I'm currently a research fellow at Professor Fregni's lab here in Boston. And as she said, I am a PPCR alumna from last year. And so we were talking, the fellows were talking to Professor Fregni, and something that they used to do in the lab is a journal club, just so that everyone can keep up to date with the most recent discoveries and findings that relate to the neuromodulation field. But since the pandemic hit, there haven't been a lot of fellows in the lab, so we thought it might be a good idea to bring it to PPCR, just because there are a lot of you, and it's always good to keep up to date with current findings in the medical field, and also it's always good to practice our critical analysis of different studies, just because that's how you'll apply everything that we're learning in PPCR. So so just to contextualize a bit, what is a journal club? I think some of you might already know what it is, but it's just basically a group of people, either students, scientists, health professionals, that get together to discuss recent publications, new publications that have been published in their fields. And it's a good way for us to acquire a lot of different skills, such as critical analysis of study designs. So analyzing if the studies are actually methodologically accurate, and if they're right, and if their quality is good. Also, it's a good way, like we said, to keep up with current findings. Given the large amount of publications that have been going on recently, you can't possibly keep up with everything. And this journal club is a way that we can at least find the latest discoveries and see what is most relevant for clinical practice in this day and age. Also, relating a little to PPCR, this is a way that we get to practice putting on our researcher versus our clinician's hat and critically analyzing the information that we see in different studies, rather than just absorbing it and taking it as the absolute truth. And it's also a good place to improve debate and presentation skills. I'm currently improving my presentation skills while I'm presenting to everyone. And but we can also all improve our discussion skills. So please feel free to participate, turn on your mics. You can also put it in the chat. I have it open so that we can discuss a few things. And so, yes, feel free. I know that sometimes we are afraid of saying the wrong thing, but nothing's wrong here. We're all students. We're all learning together. And that's what I wanted to say as well. By no means my views are superior or more correct than any of yours. So feel free, if you think anything I say is not right, just go ahead and say it and we can discuss together, because that's the whole goal here. So the paper that we're going to discuss this week is called Central Sensitization in Chronic Pain Conditions, Latest Discoveries and Their Potential for Precision Medicine. This is an important topic because chronic pain is something that doesn't matter your specialty, doesn't matter your health profession, you're going to see it in one way or another. So physical therapists, they're going to deal with chronic pain. Any given specialty in medicine is going to deal with chronic pain. Nurses are going to deal with chronic pain. So it doesn't matter where you are. In your medical profession, in your health profession, you're going to have to deal with it. So it's important to understand the mechanisms behind it and why it has been such a difficult condition to manage. So the one thing is that this article is not a clinical trial, but it is a narrative review. And I know that everyone is very anxious wanting to read clinical trials because of everything that you're learning in PPCR, but you're not always going to only learn and read clinical trials. So it's important for us to critically analyze different types of studies, such as a narrative review, such as observational studies. So this is a way for us to learn more about a topic that is important in medicine and also in healthcare in general, and also to practice our critical analysis skills. So for us to contextualize, even though there's no methodology here that we can analyze, there are a few things that we can look for in a review that may categorize it as a good review. So one of those things is that the purpose of a review is to summarize research, but not only summarize research, also provide a critical analysis to the information that is being given to us. So we are looking out for in this paper conclusions that and takes that the authors are giving regarding the information and the data that they're providing. Also, a review should be more focused discussion rather than a generalized one, because then we could just get a textbook on any given subject and just read that. We want a more comprehensive, a more structured and objective view. So if the review goes on and on about a topic, that might not be the best way. And even though it's not a systematic review, any review must have in some sort a systematic search, meaning they must have a given search strategy. Just because if they don't, they're not approaching and getting a large range of articles that might give them the information they need to summarize a given topic. So having a search strategy is very important. And so the search strategy for this paper is right here. They research papers in PubMed and Web of Science with these especially significant keywords such as central sensitization, chronic pain, nociplastic pain, and different conditions such as osteoarthritis, headache, rheumatoid arthritis. They also mentioned that they give preference for systematic reviews, meta-analysis, cohort studies, and fully powered randomized clinical trials. So they did a systematic review to reach the largest amount of papers that they could to bring the latest discoveries of chronic pain and the mechanism that they're trying to discuss. So since this is a discussion, I am going to be asking everyone a few questions so that everyone can participate. So please look out for, while we're presenting, the review's main takes and their analysis. So what they're going to do with the information that they're providing us, and also definitions and applications of the concepts that are in the review. So for the introduction and the background that the review brings to us, they contextualize chronic pain. They say that chronic pain is a large burden in the healthcare system, especially because it is time consuming to manage, it is more expensive, and it is costly, and it is a large burden in patients. They also say that because of this issue in managing chronic pain, the World Health Organization also characterizes chronic pain as a disease on its own. And there is a very difficult, like I said, managing situation behind chronic pain. And this, one of the explanations between this difficult management is that peripheral mechanisms of chronic pain conditions don't usually explain pain magnitude. So patients are having a lot of pain, but they're not having a lot of peripheral stimuli for their pain. Oops, sorry. My bad. But they're not having enough stimuli to justify the amount of pain that they're feeling. And that's where central sensitization comes in. So the review makes a case of defining central sensitization inside this review as an amplification. Sorry, the thing is on. So an amplification of neural signaling within the central nervous system that elicits pain hypersensitivity. So here we can stop and just reflect, why are they making a case of saying, in this review we are defining central sensitization in this way? Isn't there only like one way that we can define central sensitization? How can we apply that to also how different conditions are defined in clinical trials? What do you think about that? You can use the chat if you don't want to speak. It's totally fine. Okay, so so basically, there are different ways and different methods of diagnosis of different conditions and different. Sorry. Oh, I thought someone was going to speak, but so there are different ways that different conditions. Yes, exactly. So Jose, I don't know how you say it, I'm sorry, but he just put in the chat that you need to specify your definition as to justify the papers that you are using in your review. Exactly, because different papers can define different conditions in different ways because there are different guidelines, different diagnosis methods. So for you to get a comprehensive analysis of a specific condition, then you need to have a specific definition that you're relating to. And so within the definition of central sensitization, they also explain a new concept called nociplastic pain. Nociplastic pain can relate to other definitions of pain, such as nociceptive and neuropathic pain. Neuropathic pain is the pain that is caused by damage to neural tissues, so nervous system tissues, so nerves and everything like that. And nociceptive pain is pain that is received through a stimulus that is non-neural, so it's pain that is felt in tissue that is non-neural. And nociplastic pain is a new concept that comes into central sensitization, meaning that it's a nociceptive stimulus that is caused by sensitization, meaning that hypersensitivity is what's causing this type of pain. With all of these definitions, central sensitization has been seen as something that can predict poor treatment outcome in patients with chronic pain. And because some patients might have central sensitization, that opens space for pain medication matching and individualized treatment for those patients that have central sensitization. So this brings us to the purpose of the review, which is to provide an up-to-date evidence-based summary of the latest discoveries regarding central sensitization in patients with chronic pain and the potential for applying these discoveries to precision medicine approaches. By reading this, what are we thinking of? Like, what are the key words of the purpose? Do we think this purpose is feasible for a narrative review? What are we thinking? Evidence-based is one, yes. So chronic pain, sure, lack of precision approaches, yeah. So precision medicine could be that summary, exactly. I also think central sensitization can also be one of the keywords. And so basically what we're looking for with this purpose is with the purpose in the review is that we're looking for summarized information that is evidence-based regarding how central sensitization mechanisms act in patients with chronic pain and how that can be applied with in precision medicine. So we're going to be looking out for that and see if the review answers its purpose. So then the review brings us how central sensitization is present in patients with rheumatic disease, which are diseases that are prevalent conditions with chronic pain. And so one of the things that they introduce is that a hallmark for central sensitization is an increased sensitivity in healthy tissue or undamaged areas of the body, meaning that when you have a chronic pain condition, you usually only feel the pain. You're usually only supposed to feel the pain in the area that is being affected, so the tissue that is damaged. But with central sensitization, you're feeling that all over your body, not necessarily only in the area that has been damaged. So that is a hallmark of central sensitization. And they also introduce to us quantitative sensory testing, or QST. And quantitative sensory testing is the way that we can quantify and classify the amount of central sensitization, meaning the response of the sensory response we have to sensory stimuli, be that pain, thermal, pressure, or even vibratory stimulus. This means that we can quantify central sensitization by the amount of pain one of these stimuli cause. So if you're applying heat and a low temperature causes you pain, that might mean that you have high central sensitization. In other conditions, if you're very much tolerant to heat, that means you have lower central sensitization or don't have central sensitization at all. And so central sensitization in rheumatological practices are found in conditions with high amount of chronic pain, such as Ehlers-Danlos syndrome, osteoarthritis, fibromyalgia, and rheumatoid arthritis. However, the review then brings that a lot of studies find patient-to-patient variability regarding the amount of central sensitization in those conditions. So what this means is basically that not everyone having a specific condition might have central sensitization while experiencing chronic pain. And this may vary within each condition. For instance, the majority of patients in fibromyalgia might have central sensitization, but when it comes to osteoarthritis, only a subgroup of those patients might be experiencing central sensitization. And so there might be a lot of inconsistencies regarding results because of this patient-to-patient variability. And this is why the review brings this analysis, and then we can analyze that together. So the review says that inconsistency among results can be attributed to different methodologies applied or to different patient populations characterized by different degrees of central sensitization. What do they want us to conclude from that? Do they want us to conclude that central sensitization is not a mechanism that can be generalized, or what are we thinking that we can conclude with that analysis? Sorry. Yes, it is individual. It depends on the patient. There can be confounders. Also depends on the type of disease, and it's different between populations or from subject to subject. Exactly. I'm trying to read everything that you guys are putting, but so what they're trying to say is that there is a lot of different ways that central sensitization can be seen in different patients, not only in different diseases, but in different subsets of groups within the diseases. And so this is why they want to analyze, right, going back to the purpose of the review, they want to analyze how it can be applied into precision medicine, which is individualized treatment according to patient category, right? So they then bring how we can apply central sensitization and how can we diagnose central sensitization. So as we saw, quantitative sensory testing is a way that we can analyze if central sensitization is present in a group of patients, because it is the sensory system response to sensory stimuli. So by applying this practical test of applying a thermal or a pressure stimuli to these patients, we can analyze if they have higher sensitivity to it, normal sensitivity to it, lower sensitivity to it. But there are also other methods that we can analyze, such as the central sensitization inventory, that in contrast is not something that you're applying to the patients, but self-reported symptoms that the patients might have that might correlate to central sensitization, meaning they can report that they are hypersensitive to pain, that they're experiencing fatigue or sleep disturbance because of increased sensitivity, and then these might be features that relate to central sensitization. However, there is a difference between when you're diagnosing central sensitization in patients with the reported inventory compared to when we're using T. And this means that there might be other things that we have to consider when we're using different methods of diagnosis for central sensitization. For example, the review brings that QST might need to take into consideration other aspects, such as the age of the patient, their ethnicity and racial status, the sex, and the body size of the pain. And then they bring a study that can support this important information, which says that women are more sensitive than men when it comes to pain. But as they get older, as people get older, the biological sex influence on this sensitivity does not matter that much. So if you're looking into women that are older and have a higher sensitivity to a stimulus, you might not only consider that, oh, it's because my patient is a woman, but that might be an alteration of central sensitization. Yes. And there are other ways that and that might make it a little difficult and a little complicated to diagnose central sensitization. And also the review provides that there are other different ways that might influence the diagnosis of central sensitization, such as other questionnaires that might not be directly related to that diagnosis, such as the pain detect diagnosis, such as the pain detect questionnaire, which is more focused on neuropathic pain. But it has been found to diagnose central sensitization in patient groups with osteoarthritis. Now, it is still an ongoing study, right? So how central sensitization can be diagnosed, because it might be a complicated process to diagnose. And so the study even brings new markers that might be plausible to diagnose central sensitization and to help of conditions might have central sensitization into them. For instance, they bring up this trial that says that in addition to slowly repeat evoked pain responses, which is a novel protocol, not QST, it's not CSI, it's not a pain detect, can find central sensitization symptoms and enhance the diagnosis of fibromyalgia. So central sensitization can be used to if sensitization features that can be used to enhance the diagnosis of conditions that are known to have those features. So given all of this, there is a lot that we can use to diagnose central sensitization, and there are no consensus guidelines that are going to guide us to say, oh, this is the way that you're going to diagnose central sensitization. So the review brings something new, which is the way that clinicians might look out for central sensitization diagnosis. And the first thing is to exclude neuropathic pain, so the presence of neuropathic pain. Also assess if neuroanatomic plausibility to the pain distribution. So if you have something that is only focused on joints, and that is the nature of your disease, that might not be unplausible, and that might mean that patients don't have central sensitization. So that's something that you can analyze with the QST. And also having self-reported symptoms related to central sensitization. And so like hyperalgesia or hypersensitivity, everything might be related to central sensitization. But then if it's so difficult to diagnose central sensitization, why are we trying to use this as a method of diagnosis for other conditions that have chronic pain? And that is exactly why the review brings another application of central sensitization, which might be for the prognosis of different conditions. So not thinking, oh, central sensitization, this might help with the diagnosis of something, but oh, this patient has this condition, so they might have central sensitization, and that might predict something about their treatment. So central sensitization might be useful in determining whether a favorable outcome is likely regarding a specific treatment. And so the review brings a few studies that show that this is important in patients with different conditions, such as osteoarthritis. And they say that pain-free patients with increased pain sensitivity, which is a feature of central sensitization, are twice as likely to develop chronic knee pain in a follow-up of 2 years. So why is this important? What do you take from this conclusion of this study? So we can see that increased pain sensitivity, sorry. So what I asked was that what can we conclude from this study that found that pain-free patients with increased pain sensitivity are twice as likely to develop chronic knee pain? And just to move things along, I'm just saying that increased pain sensitivity might make these patients is a predictor of chronic knee pain in the long term. So knowing if a patient has central sensitization might be interesting, because it might dictate what type of what type of treatments might have to be done to prevent chronic pain from happening in these patients. And that is exactly what the review brings, that maybe amelioration or prevention of pain sensitization can prevent onset of chronic pain. And so this is something interesting that we can discuss. Do you think that narrative reviews can generate hypotheses, can generate further questions that can be answered to other studies? Yeah. Yeah.
Yes.
Yes, they can.
Yes.
Exactly. So they can do that because they are bringing us information and they're localizing gaps in the literature that are going to help justify or understand different concepts within different fields. So central sensitization shows that it might be a predictor of different outcomes, right, in patient treatment. So they can suggest that amelioration or prevention of pain sensitization can prevent onset of chronic pain, and that is something that can be investigated in other trials. They're also bringing us information about other types of predictions that central sensitization can have, which is when you're diagnosed through the CSI, so they're tying in the diagnosis of central sensitization to its function as a prognostic factor, with increased pain sensitivity. There is a higher pain disability notice in a 3-month follow-up for patients with musculoskeletal disorders. So this basically means that central sensitization might be also a predictor of pain disability, not only of chronic pain. So this is also important because it might dictate what you're going to do for these patients. However, what we saw here, right, that the CSI is the one that showed that increased pain sensitivity can have higher pain disability. However, the review also brings that the diagnosis of central sensitization might find inconsistent findings. So a lot of QST measured central sensitizations did not show that it was a good predictor of likely outcomes for patients. But a lot of self-reported measures showed that central sensitization was a good predictor. So once we get that, once the review brings that to us, what are we thinking? Like, what can we interpret? So I brought here a little question. So upon reading that there are inconsistencies, and some studies show that central sensitization might be a good predictor, and others show that they might not be a good predictor. What can we conclude about central sensitization as a predictive factor? That the pool studies have poor methodologies, that negative studies are underpowered, and that's why they didn't show it as a good predictive factor, that central sensitization has not shown to be a good predictor of favorable patient outcomes, or that more research on central sensitization is needed to give us a definitive answer. Okay. Yeah. Yeah. So technically, every single one of these alternatives can be true. It can be true that the pool studies have poor methodologies, and that's why they're inconsistent, or that negative studies might be underpowered, but they might also not be underpowered. And it can also show that it has not been a good predictor, because this is what we're testing, right? So if there's no conclusion, that means that it hasn't yet been shown to be a good predictor. But I agree that more research on central sensitization is needed to give us a definitive answer about its role as a prognostic factor. And that is how they are going to tie into different studies that might show how this might make more sense, right? So how central sensitization can be a good prognostic factor. They bring us the example of surgery in the case of total knee and hip replacement, so total arthroplasty for patients with osteoarthritis. They say that patients that have preoperative central sensitization, so higher pain sensitivity, they are more likely to have more pain, worse quality of life, worse disability, and greater treatment dissatisfaction after surgery, so post-operatively. And this is a thing that this is how they're tying into precision medicine, right? Because after noticing this is how the method of multimodal analgesia was put into investigation. And so seeing that patients that have higher central sensitization preoperatively made surgeons and anesthesiologists say that more medication for analgesia might be needed to prevent these worse outcomes after the operation. And so although this is something that is logical and came about from these findings, randomized clinical trials are rare, but observational studies show that this type of analgesia has reduced post-operative pain. And so this is important because this is how we can individualize treatment, and how the review brings us the way that we can individualize treatment regarding patients that have central sensitization. So as we saw, that is the first type of treatment, right, for surgical reasons. Is there any type of treatment for central sensitization? And since we're talking about central sensitization, not peripheral sensitization, it's more logical that a CNS target would be the best type of treatment, but that not necessarily is the case, because peripheral tissues can also induce and maintain central sensitization, because that is how increased pain sensitivity might occur, because a tissue is sending more nociceptive signals to the brain. So because of that, there might be a space for bottom-up treatments that have the potential to reduce central sensitization. But it is important to notice that because it is central, that might not be the main mechanism by which central sensitization is applied. So keeping CNS as a target, and medications and treatments that target central nervous system might be a better option. And so they bring us another example, again with total hip and knee replacement, in which after doing total hip and knee replacement, patients had the normalization of central sensitization measures. But that is weird, because we just talked about how total knee replacement and hip replacement gave the patients worse outcomes. How come this is a way that is normalizing the central sensitization measures? What do we think that could be a justification for having like two completely different results with the same treatment? So sure, because pain is subjective, yes. And just to relate to what you have been studying, exactly, different population characteristics relating to what you have been studying regarding study populations. The populations in these studies might be different, and so they might be providing different mechanisms for central sensitization. And this is important because, yes, that is also true, that the answer for pain mechanism is not exactly central sensitization. So this one might be a different population than those in which a worse outcome was predicted. And this is important because the review bringing this comparison, right, between two studies gives us two different two more understandings of central sensitization, how it works. The first one is that central sensitization can act in different magnitudes. So people with higher central sensitization, I'm going to say CS just because it's a lot to say, but people with a higher CS might have a different response. So they might have worse outcomes, and people with lower CS might have better outcomes with peripheral treatment. However, there might be another mechanism, meaning that CS works in different pathways, meaning that there might be a peripheral pathway in which CS is maintained and induced, like the one that we see here in this study, or there might be a more central pathway in which CS is induced. And that is why different treatments might work in different populations, because these might vary. So the review brings that suggests a multifactorial disease model, which is exactly this. There are different ways that central sensitization might function. And also someone in the chat just said that peripheral sensitization is also an important factor. So there might be a lot of factors that are being applied when talking about central sensitization. So giving the possibility that central sensitization might predict worse outcomes, it is important that there might be a treatment for central sensitization. And then the review brings different types of pharmacological and non-pharmacological medications that might be important to treat this type of condition. And the first one is antidepressants that the review shows simply states that have been have had a positive effect in treating central sensitization, and then anticonvulsants that might have a different aspect to it. So the main studied ones are gabapentin and pregabalin, and some systematic reviews have shown different results regarding its effectiveness regarding different conditions. So a moderate systematic review analyzing moderate to high quality evidence claims that it is not effective for lumbar radicular pain. But another systematic review says that there is insufficient evidence to prove or disprove effectiveness for fibromyalgia. So different conditions might provide different types of effectiveness for the treatment of central sensitization. The review then brings that 3 randomized clinical trials and a large randomized placebo-controlled trial found effectiveness for pregabalin as a treatment for central sensitization in patients with fibromyalgia. But why would they bring this information of 3 randomized clinical trials and another RCT, after they bring a meta-analysis that says there is insufficient evidence to prove or disprove effectiveness? Because technically, systematic reviews are supposed to be higher up, right, than clinical trials because they evaluate all clinical trials. Why do we think that they brought this as an evidence that it might be effective after they mentioned that there isn't sufficient evidence for its to confirm its effectiveness? Mm-hmm. Okay, yeah. So there are a lot of things that might be occurring here. So the meta-analysis might not have evaluated these different trials. We don't know how they evaluated and how they chose the trials that they were evaluating. And also, since we're inside a review, we're not inside a system review or a meta-analysis, we don't know the quality of the studies or the quality of the meta-analysis that is being provided to us. So we can't know exactly why each one gave conflicting results. But one of the justifications that the review brings is that the effect might not be detected in heterogeneous populations. And this might explain why some RCTs found effectiveness and the meta-analysis did not find sufficient evidence, just because, as we've been talking about, there might be many different populations inside the central sensitization system, and the studies might be heterogeneous because of that. They also bring the review of opioids. However, they have been shown that studies show that opioids reduce in short term, but increase hyperalgesia and central sensitization with prolonged use. So they should not be supported as a treatment for central sensitization. And this makes sense if we're thinking about different conditions that have chronic pain, because opioids, for example, if we're thinking about fibromyalgia, opioids are not the best treatments because they are not going to target well. And this might be because a lot of fibromyalgia patients have central sensitization, and the use of opioids might be increasing that central sensitization throughout time if you're using that a long way. Then the review brings a series of non-pharmacological treatments that might be useful. And so they talk about physical therapy, exercise, emotional functioning therapy. And this is interesting because by bringing this as a possible central sensitization treatment, they raise the hypothesis that central sensitization might also be connected to an emotional perception of pain, not only a subjective one, but a directly emotional one. Then creating another hypothesis, as we talked about. Then they bring the transcutaneous electrical nerve stimulation. as a possible way, and dietary patterns that might also relate to central sensitization. However, they say that this is an analysis that we can analyze together, right, from the review. They say that there are a lot of small effect sizes, and this might have to do with central sensitization magnitude. But what are other reasons that the effect sizes might be small and might not be giving us a lot of information or a lot of evidence-based support for non-pharmacological treatments? So we can think that they might not be compared with different specific types of treatment, since there is no gold standard for treatment for central sensitization yet. And that is something that they bring with a different CS magnitudes and also different populations with specific CS treatments. That means that different specific populations with specific CS features, such as hyperalgesia, widespread pain, lowered pressure thresholds, they might have a greater influence. So non-pharmacological treatments might work better on them, but they might not be representative of the entire population that has central sensitization. Also, the review brings that there's a lack of trials comparing pharmacological and non-pharmacological treatments for central sensitization. This is important because once they bring this, what if we're reading this review, what are we thinking now? There's a lack of trials comparing pharmacological versus non-pharmacological treatments for central sensitization. Yeah, okay, so Cesar's answer is basically that. So let's do it. So there is a need for there is a need for more trials to exist regarding regarding this comparison, so that we understand better the effect sizes and the influence that these treatments might have on central sensitization. So this review, as we're seeing, is creating a lot of different hypotheses that might be applied in different clinical trials regarding central sensitization to improve the knowledge that we already have regarding them. So this is how we come into precision for chronic pain in rheumatology. So we have had a summarized information about what is known about central sensitization, how it acts in different rheumatic diseases, how it is diagnosed, and how it can be used as a prognostic factor, and what can be possible ways of treatment. And so this is important because this is how we're going to apply central sensitization into precision medicine for chronic pain. Because now that we know that central sensitization might be a mechanism, and we know what type of medications might be worth it, or might be useful in ameliorating these symptoms, we can use it to better treat chronic pain, which is already difficult to manage. So basically, the first definition of precision medicine is the susceptibility to the biology of or the prognosis of a disease according to each patient, which allows us to have individualized treatments for each of these patients. And this is important regarding central sensitization and the treatment for chronic pain, because several different studies convey some results that are interesting, that advocate actually for the use of precision medicine in chronic pain, such as a post hoc analysis that was found in a randomized clinical trial of patients with knee osteoarthritis that showed that a medication, duloxetine, reduced pain in patients with 3 or more painful points, but not in patients that have 3 or less painful points. This can have a myriad of different mechanisms that have been put into effect, and central sensitization might be one of them. So when we're dividing these patients, we can find central sensitization methods, and we can also realize that there are different subgroups that are going to respond better to different treatments. Also, another study found that patients with chronic low back pain with central sensitization features responded better to duloxetine compared to patients without those features. So that is important because that is how we're going to apply central sensitization into the precision medicine and individualized treatments of patients with chronic pain, because we see that patients that have CS features respond better than those that don't. So it's already a way that we can realize or maybe hypothesize, right? Because this is not something that we're taking to practice because it hasn't been completely proven yet. But we can think that duloxetine might be useful for patients that have central sensitization. So we're looking for that in patients with low back pain. And another trial showed that there was no effect in imipramine as a pain medication, but those that had higher sensitivity, so higher CS, had a greater pain relief with this medication. So this suggests that there is possible individualized treatments matching pain phenotypes in osteoarthritis and low back pain patients, but also that a multimodal effect, so more than one medication, might be more useful for patients with central sensitization. And that's why they conclude that patients without central sensitization features might benefit from unimodal treatment. Why are they bringing this here? Why are they saying, why are they talking about patients with no central sensitization features if we're analyzing central sensitization in this review? Mm-hmm. Yeah, to compare them and to say that multimodal might not be for everyone. So they're actually supporting their claim that there are different groups that respond differently according to pain sensitivity. And patients without central sensitization might be simpler to treat. So they might be managed easier and they don't have to have the burden of taking several medications when they can only take one. So knowing which patients have central sensitization features and those that don't have central sensitization features might be important to make a more focalized and a more practical and effective treatment for these patients. And so they conclude, though, with everything that we're seeing, that there aren't enough evidence to prove that central sensitization can be used to provide precision medicine in rheumatology practice, even though we saw everything that we saw. Why do we think that this is the conclusion? If they provided systematic reviews, randomized clinical trials, why are we thinking that this is the conclusion that they reached regarding precision medicine and central sensitization? Mm-hmm. Yeah. So sorry, they're saying lack of power, quality of study, and that is very true. Because of the inconsistency, also very true. So what the trial brings is that prospective trials are not available. So most of them are observational trials when they're focusing in precision medicine. And yes, that is very true as well, that there's no standard diagnostic for central sensitization. And also what everyone has been saying, that there's low strength and number of studies. So if we don't have studies that have high power, that they are good, they have good methodology, and that they are applied without bias, we cannot conclude something just because a lot of studies show that. And so this is important because first, narrative reviews are supposed to be a compilation of knowledge. So they're not supposed to say, oh, this can be applied to clinical practice now, but they're also concluding something that's plausible with the information that they provided to us. And so the main conclusions of the review are that central sensitization features in many different rheumatologic conditions contribute to a shift in the way we understand chronic pain, providing different treatment pathway opportunities. So they're not saying that central sensitization is the way to go. They're not saying that this is the way that we have to treat chronic pain now. They are generating a hypothesis, which is that different treatment pathways might be possible because central sensitization might be contributing to chronic pain. So that is one important thing. And within each chronic pain condition, there is great patient-to-patient variability. We've seen this throughout the review, right? We've seen that heterogeneous populations interfere in treatment, in prognosis, and in diagnosis of central sensitization. And so this patient-to-patient variability regards to magnitude and presence of central sensitization, indicating the need for individualized treatments, which from this conclusion, what can we also what is a generating hypothesis that we can expect for people to study? So basically, here we're saying that precision medicine needs to be studied more because of these patient-to-patient variability. Exactly. So more targeted approaches can be achieved in chronic pain. And given the predictive factor of central sensitization features for negative outcomes, there might be non-pharmacological and pharmacological treatments to reduce central sensitization impact. So there might be a indirect way of dealing with chronic pain because we have ways to treat central sensitization. So if the patient has central sensitization, we can treat that, and that can ameliorate the chronic pain or even prevent the chronic pain, like we saw in patients that have conditions that are susceptible to chronic pain, such as osteoarthritis. And there's a possibility for matching multimodal and unimodal treatment approaches to different CSP phenotypes seen in rheumatology practices. So here we see a lot of different things that the review brought to us. They are summarizing everything that they brought to us, and they are also creating different hypotheses that might be needed to that might be studied in future clinical trials, meaning the possibility for matching multimodal or unimodal treatment. So we can investigate multimodal and unimodal treatments in patients with central sensitization to better understand how this relationship works. And so this review just brings everything together in the end, just to say that central sensitization might be a factor that can help with precision medicine in patients with chronic pain. So yes, I left my email here just in case anyone has any questions, anyone wants to discuss more about it. What are your last impressions of the review? Do you think it's a good review? Do you think that it sets the stage for different possibilities? What are we thinking? Also, thank you. Thank you.
Great, everyone. Thank you, Anna, once more for your time and for preparing this great review of this novel paper. As you saw, it was published in March, and right now it was published in May on the Lancet Journal. And so we're really happy to have you, and thank you, Anna, once more. And if you would like to contact us, also the presentation will be posted on Google Classroom. And we appreciate all of you for joining. As we said before, this is an optional activity, and we hope that you can enjoy it every month with Anna and Paulo, both of them working in the lab right now. So have a nice evening, and thank you, Anna, for your excellent work. Have a nice night.
Thank you so much for having me, and thank you everyone for coming. And yeah, thank you for your time.